Good morning, everybody. So here we are already at day 3 of HIMSS, halfway through the conference. And as you can see and hear, there's a absolute sea of vendors and technology and education, all for us to be able to improve the experience of our patient and caregivers. For those of us involved in technology, of course, it's a daunting task to select not only the right technology, but the interoperability of all those technologies. But equally important is for us to think about a thoughtful approach for how we're going to actually deploy technology to achieve the ultimate in actual adoption of that technology. So I'm grateful that Ascom invited me here today to talk about the successful approach that we used and how we were able to improve unit communication, reduce noise, and increase the nurse and patient satisfaction in just 60 days. So my name is Ted Pless, and I am the Director of Technology Solutions at Mission Health in Asheville, North Carolina. And today what I'm going to be talking about is the situation that we had as far as the communications in our caregiver space, a plan that we came up with how we would deploy Ascom technology to improve those communications, the pilot we conducted and the approach that we took, as well as the results that we achieved. So a little bit about Mission Health. We're a not-for-profit health system located in Western North Carolina. We have 6 acute care hospitals and 1 non-acute hospital with 763 beds at our flagship facility. We cover over 120 locations of ambulatory practices, over 18 counties serving about 1 million people. We have 15 specialties and subspecialties, about 12,000 providers, and 1,000 physicians. And we're a $1.8 billion corporation that has a 75-25 Medicare mix. So it's challenging for us to be able to provide all these technologies when we're operating generally at a loss and trying to cover all of that with a 25% self-pay. We are a top 15 Truven Health System Analytics winner, 5 years. Last year in 2017. So I'm going to start out talking a little bit about the situation that we found ourselves in. We had disjointed, inefficient clinical communication, and it was rapidly getting more complex and difficult to manage. We had multiple modalities for communicating. So if you walked out onto the clinical floor, you would commonly see a mix of pagers, Wi-Fi phones, cell phones. In many cases, clinicians were carrying multiple devices. Each of these devices were for their own separate application that needed integration to that device. And of course, there were not only competing devices, but competing middlewares. And when I say middleware, I'm talking about the software that actually controls the communication from the application to the device. We had also had some prior unsuccessful deployments of smartphones and Wi-Fi handsets, so we were running into a situation where the care providers had started to lose confidence in the IT department. And one of the things that prompted was us to take a look at how we were engaging our customers from a strategic standpoint. So our CIO made a commitment to develop a program where we would get out of this vicious cycle we were in where salespeople were coming to clinical leaders and selling the newest shiny bright device, and they were coming to IT and saying, we've paid for this, we need you guys to implement it. We would implement it successfully, but it would be a complete failure because it didn't meet any of their expectations or needs, because nobody bothered to do that analysis up front. So we started out with some strategic engagement and partners that would go out and talk to our caregiver leaders and say, what's your vision? What are your needs for the next 12 to 18 months to 3 years? So we can go out and locate the right solution for you based on requirements. And so we'll do that requirements gathering with some business analysts. We'll architect and design it properly, and then we'll make sure it's the right shiny device. And when we put it in, we're going to put it in a way that will be successful because we'll provide the training and support that's required. So what we needed was a strategic plan, and that is what this presentation is about. So this was one of the first successful IT projects we've had since we developed that new methodology. So we knew what we wanted up front. We needed a single communication device across the entire enterprise. No more multiple pagers, Wi-Fi sets, cell phones, just one device. it had to be reliable for voice communication using our Wi-Fi network. And we wanted to make sure that if we were going to send messages, text messages, that they were secure and they operated like the SMS text messaging that we're all familiar with on our own personal cell phones. We also need the ability to receive clinical device alerts to the phone. So we wanted that ability to not only communicate with just voice and text, but ultimately to be able to generate and send alerts when a patient or medical device needed attention. Some things we wanted to also keep in mind were barcode scanning for future applications like meds administration and positive patient ID. Additionally, staff duress. If our patient clinical caregivers got into trouble, we wanted them to have a way using the device to make sure they were able to call for help, along with presence and proximity awareness. The other thing we needed besides a device that would meet these criteria was a common middleware platform. So again, we didn't want lots of different middlewares that had to speak to different devices, just one. And then we wanted the ability to be able to integrate multiple systems into it. So we know we have our EHR, biomedical devices, and alerts that would come into a common communications platform and then go to this common communication device that we had selected for the enterprise. And also, a goal was to reduce complexity of managing multiple platforms. In addition to what we knew we wanted, we certainly knew what we did not want because we'd already lived through that. And that included having a communication platform that supported the EMR and the biomedical devices, a separate communication platform for doing alerting, and even a third communication platform for telemetry monitoring, all of which were using their own dedicated device, which made 3 different solutions for us to be able to support. But then we had to figure out how to pay for the integration to make all of those things work together. So this is the system that we had and we didn't want to have. So the first step was getting clear on what is the device that we're going to choose for the enterprise-wide deployment. And of course, we selected the Ascom Myco phone for a number of reasons I'll go through, because it had all the desired attributes that we were looking for. First and foremost, it was health-grade hardware. That meant it was easily cleaned and disinfected. It looks like a medical device. It doesn't look like your everyday average cell phone. And there was no additional clip or case that you had to buy. You could drop this device from 5 feet up onto the concrete and it wouldn't break. If we were to buy traditional consumer-grade cell phones, we would have to buy a case, we'd have to buy a clip. The battery life probably wouldn't be long enough, and by the time you accommodate for all of that, you're adding an extra $150 to $200 to the device. So this had that going for it. Secondly, one of the things that we were hearing from clinicians as we began to talk to them about what their needs were is, hey, a lot of the vendors are showing me devices that I can use for this, but they're big and they're heavy and it requires 2 hands to operate, which I often don't have both hands free. And when I put it in my pocket, either it doesn't fit or it's so heavy it's pulling my scrubs down. So again, looking for something small, which this was certainly good and lightweight. Long battery life was another option. Our clinicians, we have 2 shifts, 2 12-hour shifts, and what we were hoping to avoid was having clinicians have to stop and swap batteries or recharge a phone. So we wanted something that would last, and this has a 12-hour battery life, and through our testing was lasting throughout an entire shift. But it also has a nice hot swap battery, so if for whatever reason their battery was running low, they can simply change the battery easier. We deployed enough devices so the clinician could simply check in a phone and check out another device that was fresh. And we didn't want there to be the need to have to log in, so I'm going to address how we handled that. Some technical requirements: it also had to be reliable, scalable, manageable. And additionally, we wanted it to be multi-platform. So looking down the road, while we started out just with the Myco handset, we also were happy that the platform, the same middleware, would run on a bring-your-own-device regular cell phone, so that physicians or other use cases where they didn't want to carry the Myco 2, they could run the same software on their personal device and be able to communicate with the clinicians that were on the floor that had the Myco phones. Lastly, you have certain use cases and certain roles, like the health unit coordinator or unit secretary, that has to communicate with a lot of caregivers. And of course, the last thing we want her doing is sitting at the desk, or him, all day long and text on this little tiny phone. So the application equally runs on a desktop so that those clinicians can be communicated with by the HUC just by typing messages in. So same application or middleware across 3 different devices. So further on down the road, looking ahead, and this was not part of our pilot, but we wanted to make sure that the device we selected had the ability to increase functionality and deal with multiple use cases. So one of the things that's fascinating about the Myco solution is that it can accept telemetry alerts directly to the phone, where the caregiver can simply either accept the alert and deal with it, or they can say, I'm busy, with a single click, and it will automatically escalate to the next care team member taking care of that patient. Down the road, we're looking to partnering with GE Airstrip to be able to have waveforms coming directly to the phone so that they can see real-time monitoring without having to go to the bedside. And of course, what we started with was actual communication of just forwarding of text messages and voice. So some success factors that we were looking for is, number one goal was adoption. So while a lot of other companies have chose to roll things out and just throw everything that it can do out on day one, what we were concerned about was getting that adoption. Our experience had been, if you roll out too many features on a device, if even one feature is having trouble or not working or isn't acting favorably, all of a sudden there becomes this buzz about, oh, this device doesn't work, it's crappy, and we didn't want that. So we thought, let's control rolling out things that we know that are the most needed, voice and text, making sure they're stable and that they work and that the clinicians are comfortable with it. There's a positive buzz constantly generated about what a great device this is, and then we slowly roll out one at a time additional features with training to make sure all along the way we're maintaining that image of success and positivity. Also, we wanted to make sure that assignment of devices had to be fast, easy, and reliable. And if it wasn't, the project would basically die because it wouldn't be used. So one thing I would recommend if you do this type of implementation is exactly what we do. Change is hard for people, and if people have their old tools available to them, they will always choose to use that over a new tool you're trying to push on them. So one of the greatest keys to our success was collect the old devices. So we collected all the pagers, the Wi-Fi phones, everything that they had been using. This is the only thing you have to communicate with, so we're kind of forcing the adoption. But along with that, you have to be responsible and have at-elbow support. So we had staff on the floor, we did training ahead of time and make sure that people are there to answer questions. This is a picture of actually one of our deployments in the unit. So the charging cradles are where the Myco phones go. In our initial pilot, we had 2 units of 30 staff each on 2 different shifts. So we used 60 phones. So at any one time, half the phones were checked out, the other half of the phones were charging. You can clearly see the status of the phone before you check it out. And to make sure that the device is always on, assigned, and logged in, what we implemented was a CyberNet tablet that has a badge tap reader built into it. Our clinicians go up and they tap their badge against the tablet. They then see a message on the screen. They pick any phone they want out of the cradle. When they pull it out, it is automatically, they are logged into the device. The phone number of that phone is assigned to them. They show up in the directory as online and available, and they're logged into the application. All that is critically important, and one of the great features about the Ascom solution with this badge tap checkout, because if you're going to deliver alerts to the phone and you're going to be treating patients with this device, you'd want to make sure that when you send an alert, somebody's actually going to get it. Because if I go up and I pull out a phone and I forget to log in, or Mary's coming off the shift and she hands me her phone, but I don't log into it, now when somebody sends me an alert, it's not going to the right person. So this is a very crucial step to make sure that we have in place. Reliability was also important. So we looked at our Wi-Fi networks. We wanted to make sure the device would reconnect and connect appropriately as people roam through the building. So we had certain areas to address. You have stairwells and elevators and things that you have to work. But we wanted to make sure that when the device was out of our wireless range and not on the network, it was made clear to the clinician that they were no longer connected. so the device audibly beeps when you lose connection to the network. Had to be super and fast and easy to the device swap for any reason whatsoever. Like I said, low battery charge. If there's any problem at all, you simply go, you put the phone back in the cradle, you badge tap, and you pull out another phone, and now away you go. And it doesn't matter what the phone number is because it's automatically assigned to you. People look you up through the directory, not the phone number. What's interesting about that is all of the secure text messages, communications, alerts, your profile, they are not stored on the phone. They're stored inside the system. So when I check a phone in, and then the next day I come and I check out a completely different phone, automatically all of that information follows me. My profile, my text history, it's all there for me. And for whatever reason, if the device were to walk out of the facility, it won't work because it's not on the Wi-Fi network. But even if somebody put it on a network, no data is stored itself on the phone. So, once we've selected the device and we've worked through all of this and the use cases, now we had to develop a plan for how we're going to get maximum adoption. So we identified the single device that met all the requirements, and that was the Ascom Myco 2. We decided to conduct a pilot, but here was the key. You wanted a limited number of eager adopters. And what I would encourage you to do is look for the most vocal clinicians that are in your space. A lot of times we tend to think that that's an irritation, they're always complaining, but those complainers and people that are vocal are the people you want to get this into their hands because they will quickly become your biggest champion when you solve their problem. And if they're talking about things they don't like, they're going to also talk about things they do like. So it was really important for us to identify. And we happen to have 2 units that the nurse director was quite vocal, and she was getting impatient waiting for a solution, and so she was the first one that we selected her 2 units for. Next, you want to make sure that whatever your desired outcomes are, you know those in advance, and you want to track the metrics. Things have to be measurable. So we sat down and said, what are the kinds of things we would want to track to see if this is actually working? So we worked with our partner Ascom, developed a set of metrics, how many phone calls are being placed, how many text messages are being sent, doing some survey, asking questions about is the noise on the floor been reduced, is the time it takes to get a hold of somebody shorter. Those are things that you can measure through surveys and through running reports and looking at the data. And that's important because when you get to the point where you've got all your metrics and you're ready to start your pilot, once you complete the pilot, you don't want to just automatically roll into production. You need to have that data behind you to say, is this worth moving forward with? You really want to make sure that you're just not blindly deploying something just because you bought it and you've rolled it out, right? So we wanted to make sure we made that decision. Is this the right solution? So data-driven metrics. Start with the limited features and then expand over time. I talked about communication was key. We set the expectations right up front. We are only doing voice and secure text messaging. Because of course the minute they see the device, can it do this, can it do this, can it do all these great things we're hearing about? Yes it can, but not on day one. On day one we're just doing these 2 things. Again, here's another picture of our badge tap station with the charging racks for our phones. So we started the pilot with the limited features that we would expand over time using some structured processes and defining each step as we went. And the success criteria that we measured were utilization metrics. And I'm going to go through some of those in the results to see how much the device was being used. Reliability of all the features, the call quality, the durability, how's it holding up? What do people think of the device as far as the quality compared to the other communication devices they have been using? We also wanted to track, because it's equally important, what are the undesired actions? For example, overhead paging. So we all know that HCAP scores are very important to us. So the louder the floor is, the lower those scores are going to be. So we wanted to start to measure that as well. Has this device stopped us from having to page people overhead that we can't find? Training, an absolute must, and the device has to be easy to use. So we made sure we set up training that the clinicians have to go through. We aimed for an 85% participation rate, worked with the unit coordinators for that, made sure that people got signed up and that we had lots and lots of sessions right there on the clinical floor so they didn't have to be far away from their patients or leave to go for that training. So after the end of the pilot, we took a look at our results to make a decision, is it the right solution for us and should we go forward? And the answer was a resounding yes, because for future utilization, just in the first 60 days, these 60 clinicians on these 2 units, they actually communicated 75,000 times, a total of 75,000 times between calling and texting, which averaged out to roughly about 500 communications per clinician just in that 60-day period. So it was definitely being utilized. Some other interesting things that we noticed is, as we started out, we saw that the number of texts were about 13.9 texts per every phone call. So they were clearly preferring texting to phone calls. And of course, we're seeing that as the younger generation comes in, people like to text a little bit more than just talking. Plus, talking, it requires 2 people to be available, at the same time to have that by-way conversation, as opposed to being able to send a text and somebody can respond back when it's convenient. But within the first 2 weeks, we watched that climb all the way up to a 21.9 or 22 texts per every phone call, and it stayed consistent ever since then. So utilization was definitely there. So we did a pre and post pilot survey of the caregivers in this pilot to get their opinions on some things. And so we talked about some communication perspectives, and we asked the question, or we provided a statement: we currently have a rapid and reliable means of communication within our unit staff. Only 37% agreed with that statement before we started the pilot. Once we rolled out the Ascom phones, at the end of the pilot, 77% thought that the communications, the rapid and reliable communications were there. Next statement: our current communications environment allows for timely communication of codes. Again, there was an improvement there. And the number of clinicians that thought the communication was currently a barrier was 66% before we started, and that dropped by 20 points to 46% afterwards. So basically we saw a doubling of the caregivers who agreed that their unit had rapid communications. We saw 13% increase for the ones that concurred that the environment allowed for timely communication, and a 20% reduction in the nurses who believed that communication was a barrier anymore. Moving on, some other questions that we measured was the time it takes to get a call back from a physician. That went from 17% of satisfaction before the Ascom to a 52% satisfaction afterwards. The ability to speak with a CNA basically tripled from 78% after the MICO was rolled out. It was originally 25%. Roughly similar results in the RNs. And then also being able to speak with security or locate the HUC, again, major improvements there. So the last set of questions that we asked was some statements around how the impact of this was to the caregiving environment. I feel that Ascom mobile device has reduced the number of steps I take in a day. 63% agreed with that statement. So anytime you can reduce the number of steps that your nurses are taking around the floor during the day, you're going to have some happy customers. Next one, overhead paging has been drastically reduced due to the Ascom mobile device. 43% agreed with that. In one of the units, we saw overhead paging almost completely disappear. And the badge tap function saves time during the sign-in process. And really, that's one of the things that we explained to them. And one of the wonderful things about the badge tap strategy that we used is we're moving to a VDI environment for our compute. So we're training clinicians now to go up and to tap to have their applications follow them from computer to computer using thin clients and zero-G clients. So this falls in line with that. Additionally, we have moved to a printing system where we have tap to follow me printing. So you send your print job off, you walk up to the nearest printer, and you tap your badge and your print job comes out. So here we've developed a completely ubiquitous environment where we're training clinicians. Your badge is your access to the world. Tap to print, tap to access your EMR or your applications, and tap to check out your MICO phone. So it's been a really great experience, and I would say that Ascom has been a wonderful partner. So some of our next steps, because we're further down the road than what I'm talking about here, is the pilot that happened back in August and September. So what we're looking at right now is our goal is to have 2,000 devices deployed. Right now we have 550 deployed we'll have all of our remaining caregiving teams deployed in our remote facilities by the end of July. We'll be up to around 1,125 phones. And then we're looking at rolling out the BYOD application to our physicians to use for communications on their own personal phone. So we're also looking at taking the next step, because once this is rolled out across the entire health system and everybody knows how to use the MICO to text and to phone call and they feel comfortable with it, now we're going to take the next step, and that's going to be. So we have GE telemetry today, and we have biomedical devices and meds administration and patient ID and staff duress and proximity sensing, all things that we want to implement, but we're going to take our time. We're going to go slowly and methodically to get that adoption and make sure that it's a constant success. So at this time, I'm willing to entertain any questions that anybody has, but I would certainly like to thank our host, Ascom, for inviting me here to speak today, because it's definitely a product that I definitely feel passionate about and we've had a great experience with. I think we've learned from each other. They're very responsive to us when we have problems with implementation and getting those things addressed.